Bismillahirrahmanirrahim. The quote of the day is people who have no hold over their process of thinking are likely to be ruined by the liberty of thought. A quote by the Allama Muhammad Iqbal. Today's the topic of presentation is on primary healthcare systems and referral service under the supervision of Professor Dr. Saira Afzal. The learning outlines of today's presentation is definition of primary healthcare, Alma Ata Declaration, selective primary healthcare, and health for all by the year 2000, Ottawa Charter, Millennium Development Goals, Sustainable Development Goals, philosophy and strategy of primary healthcare, key elements, principal components, advantages and constraints, and structure of primary healthcare, referral services, and at the end are the recent advances and MCQs. By the end of this presentation, participants will be able to describe what is primary healthcare and selective primary healthcare, Millennium Development Goals, Sustainable Development Goals, philosophy and strategy of primary healthcare, key elements, principal components, advantages, constraints, and structure of primary healthcare, and the referral services. Now the health for all. In 1977, 30th World Health Assembly launched a movement that is health for all by the year 2000, and it defines it as the attainment by all the people of the world by a particular date kept at that time as the year 2000 of a level of health that will permit them to lead a socially and economically productive life, and set the following guideline targets. That the number one is life expectancy at birth above 60 years. Number second is infant mortality rate below 50 per thousand live births. And number third is under 5 mortality rate below 70 per thousand live births. Now the concept of primary healthcare. In 1977, the Director General of WHO called for a new strategy, that is the health of the world has not been improved despite of uh, modern technologies and lot of expenditures. So the International Conference on Primary Healthcare was convened in Almaty in Kazakhstan in 1978, and it is attended by virtually all the member nations of the WHO and UNICEF, and it became a core concept of WHO's goal of health for all. Now the definition of primary healthcare. Primary healthcare is the essential healthcare made universally accessible to individuals and families in the community by means acceptable to them through their full participation and at a cost that the community and country can afford. It forms the integral part both of the country's health system, of which it is the nucleus, and of the overall social and economic development of the community. Now the Ottawa Charter. It is held in Ottawa, Canada in 1986, and it is intended as a plan for action to achieve health for all by the year 2000 and beyond. It established Canada as a leader in health promotion, and it outlines 5 areas that define health promotion, that are build healthy public policy, create supportive environment, strengthen community action, develop personal skills, reorient health services, and it defines prerequisites for health, that are peace, shelter, education, food, income, stable ecosystem, sustainable resources, social justice, and equity. Levinot et al. In 2008 note that effort to enhance primary health care have focused largely on accessibility to general practice physicians, contributing to confusion between primary health care and primary care for the first time in medical care. Smith, Jacobson, and Yu in 2008 make distinction between primary health care and primary care for nursing students, defining primary care as the care that is the first point of contact with the healthcare system, care that is generally narrow and biomedical in its focus. Authors, however, confuse the definitions of primary healthcare and primary care and define primary healthcare as the first point of contact with healthcare system and as the setting where short-term acute health issues are managed and most of the chronic health issues are resolved. Now the Millennium Development Goals. These are the 8 International Development Goals uh, that have to be completed by the year 2015, and it was established following the Millennium Summit of the United Nations in 2000. Following the adoption of United Nations Millennium Declaration, and it is based on the OECD DAC, that is a Development Assistance Committee, that is a principal body through which Organization for Economic Cooperation and Development deals with issues related to the cooperation with developing country. Uh, and agreed by the development ministries in shaping the 21st century strategy. The Sustainable Development Goals succeed the Millennium Development Goals in 2016. These are the 8 Millennium Development Goals. Number first is to eradicate extreme poverty and hunger and achieve universal primary education. Number third is promote gender and equality and empower women. Number fourth is reduce child mortality. Number fifth is improve maternal health. Sixth is combat HIV, AIDS, malaria, and other diseases. Seventh one is ensure environmental sustainability. And the last one is develop a global partnership for development. Health influences all these Millennium Development Goals, and all these Millennium Development Goals have an influence on health. Now, the Sustainable Development Goals. These are the collection of 17 interlinked global goals designed to be a blueprint to achieve a better and more sustainable future for all. The Sustainable Development Goals were set up in 2015 by the United Nations General Assembly, and it is intended to be achieved by the year 2030. It is included in UN resolution and called the Agenda 2030. The Sustainable Development Goals were developed in the post-2015 Development Agenda as the future to global development framework to succeed the Millennium Development Goals, which are ended in 2015. These are the 17 Sustainable Development Goals. Number one is to uh, eradicate poverty. Second is zero hunger. Third is good health and well-being. Fourth one is quality education. Fifth one is gender equality. Sixth one is clean water and sanitation. Seventh one is affordability and clean energy. Eighth one is decent work and economic growth. Number ninth is industry, innovation and infrastructure. Tenth one is reduce inequalities. 11th one is sustainable cities and communities. 12th one is responsible consumption and production. 13th is climate action. 14th one is life below water. 15th one is life on land. 16th is peace, justice and strong institutions. And 17th is partnerships from for the goals. These have the influences on health. Now the selective primary health care. In 1979, Bellagio Conference Center in Italy that was demonstrated by the Rockefeller Foundation, and it is based on a paper by Julia Welch and Kenneth S. Warren that entitled Selective Primary Healthcare: An Interim Strategy for Disease Control in Developing Countries. Selective primary healthcare framework advocated more economical, feasible approach to primary healthcare by only targeting specific areas of health and choosing the most effective treatment plan in terms of cost and effectiveness. Now the example of selective primary health care. UNICEF proposed a selective approach with examples on maternal and child health. That is, example is GOBI FFF, in which G stands for growth monitoring, O for oral rehydration, B for breastfeeding, and I for immunization, and F for female education, family planning, and food supplementation. In Africa, implementation of this GOBI FFF results in 40% decline in infant mortality in just a decade. Now, the philosophy of primary healthcare. Health is related to the availability and distribution of resources, health resources, and the socio-economic resources. Therefore, primary healthcare is concerned with equity, which means that available health and social resources are distributed justly with due consideration for those in greatest needs. Health is an integral part of our overall development. The social, cultural, economic, environmental, and biological factors are play a role. Achievement of better health requires involvement of individuals, families, and communities by adopting health behavior and healthy environment. Now the primary healthcare strategy. There is the need for change in a healthcare system. This means allocation of health resources will be carried out according to the needs, and it is intersectorial action for health has to be carried out, individual and collective responsibility for health. Now the five key elements in primary healthcare. The ultimate goal of primary healthcare is the attainment of better health services for all. It is for this reason that the WHO has identified five key elements to achieving this goal. Number one is reducing exclusion and social disparities in health. Second one is organizing health services around people's needs and expectations. Third one is integrating health into all sectors. Fourth one is pursuing collaborative models of policy dialogue. Fifth one is increasing stakeholder participation. Know the principles that guide primary healthcare. A series of basic principles identified in Almata Declaration that should be formulated in national policy in order to launch and sustain primary healthcare as part of comprehensive health system and in coordination with other sectors. Number first is equitable distribution of healthcare. According to this principle, primary care and other services to meet the main health problems in a community must be provided equally to all individuals irrespective of their gender, age, caste, color, urban, rural location, and social class. Second is community participation. In order to make the fullest use of local, national, and other available resources, community participation was considered sustainable due to its grassroots nature and emphasis on self-sufficiency as opposed to targeted approaches dependent on the international development assistance. Third one is health human resources development. Comprehensive healthcare relies on an adequate number and distribution of trained physicians, nurses, allied health professionals, community health workers, and others working as a health team and supported at the local and referral levels. And the fourth one is use of appropriate technology. Medical technology should be provided that is accessible, affordable, feasible, and culturally acceptable to the community. Fifth one is the multi-sectoral approach. Recognition that health cannot be improved by intervention within just the formal health sector. Other sectors are equally important in promoting the health and self-reliance of communities. These sectors include agriculture, education, communication, housing, public works, water and sanitation, and others. Now the components of primary healthcare. There are 8 basic components of primary healthcare. The first one is education about common health problems and what can be done to prevent and control them. Second is maternal and child health care, including family planning. Third is promotion of proper nutrition and food supply. Fourth is immunization against major infectious diseases. Fifth is an adequate supply of safe water and basic sanitation. Sixth is prevention and control of locally endemic diseases. Seventh is appropriate treatment of common diseases and injuries. Eighth is basic laboratory services and provision of essential drugs. Ninth is others are also the components in primary healthcare, that is training of health guides, health workers and health assistants, referral services, mental health, physical handicaps, and health and social care of elderly. Now the basic requirements of the primary healthcare. There are 8 A's and 3 C's in requirements of the primary healthcare. First is the appropriateness. Appropriateness means that primary healthcare service has to be properly selected and carried out by trained person in a proper way. For example, a nurse should have to be trained injecting the medicines by IM or the IV route. Second is the availability. Third is the adequacy. Adequacy means ability to provide reasonable healthcare services for a particular purpose to meet the need and demands for community. For example, to vaccination of 2000 children, 2000 vaccine doses should have to be available. Fifth one is acceptability. Acceptability means that it's socially pleasing to receiver, agreeable, or something tolerable. For example, if the maternal clinic is not good, the lady will seek it only when she experiences severe pain and avoid the recommended visits. Sixth one is affordability. Affordability means that the community able to pay the healthcare cost. And seventh one is acceptability, accessibility, and eighth is accountability. And the 3 C's in this are completeness. Completeness means that quality of being whole or perfect and having nothing missing. Number second is comprehensiveness. Comprehensive means providing care for all types of health problems and not just the medical and physical ones. And the last one is continuity. Continuity means provision of quality healthcare to community over time. For example, for chronic diseases like diabetes mellitus, hypertension, and ischemic heart disease, they need a continuous follow-up over time. Now, the primary healthcare is an approach that focuses on person, not disease, considers all determinants of health. It integrates care when there is more than one problem, uses resources to narrow differences, form the basis for other level of health systems, addresses more important problems in the community by providing preventing, curative, and rehabilitative services, organizing the development of resources aiming at promoting and maintaining health. Now the primary health care. In it, there are the preventive services and curative services. In preventive services, there are general services and care of vulnerable groups. In general services, there is health education, environment monitoring, prevention and control of endemic, epidemic, and sporadic diseases, and health office services. And care of vulnerable groups include mother and child health care services, school health services, geriatric health services, occupational health services. And in curative services include the outpatient clinics and referral systems, laboratory systems, dispensary, first aid, emergency systems. Now the advantages of primary health care. It has a better access because services are provided among the community. It is cost effective than hospital care. and it improves the community service seekers and service providers, and it has educate primary healthcare provision, obviate the need of a more specialized healthcare. Now the constraints in the primary healthcare. First is the political climate. Uh, in political climate, in several countries, the allocation of not less than 40% of the financial resources go towards defense and 20 to 30% towards debt serving. Therefore, very little is for the development. Second one is disregard of human rights. In this, the ethnic violence and social evils seem to be ragging during the current decade. This necessitated diversion of large amount of maintenance of law and order. Third is political commitment. Those holding the authority of resource allocation are influenced by high-level professionals towards the large spending on sophisticated technology in utter disregard of primary healthcare requirements. And the last one is lack of appreciation of multifaceted approach. Investments merely in the health sector are not conducted toward a healthcare style, environmental, and there also needs intersectorial approach like the agriculture, food and sanitation, environmental to address the deforestation that all has the influences on the health. Now the structure of healthcare delivery system. Healthcare services are provided to cater different diseases of varying intensities. As the level of healthcare needed varies, the healthcare can be categorized into three levels. First is the primary healthcare, second is secondary healthcare, and the third one is tertiary healthcare. Now the primary healthcare. It is the level of contact of individuals, the families, and the community with the healthcare system, bringing healthcare as close as possible to where the people live and work and constitutes the first element of continuing healthcare processes. It is the first level of contact between the individual and a health system, and the essential healthcare is provided there. Majority of prevailing health problems can be satisfactorily managed. It is closest to the people, and it is provided by the primary health center like BHUs and RSCs. Now, the Alma-Ata Declaration recommended that PSC should evolve from economic, social, culture, and political conditions of the country and its communities. Primary healthcare is for the people and by the people, addressing main health problems in the communities, and primary healthcare provides promotive, preventive, curative, and rehabilitative services as already discussed. It includes health promotion, food and nutrition, adequate water supply, basic sanitation, mother and child health, family planning, immunization, prevention of local endemic diseases, treatment of common disease, and provision of essential drugs. It is intersectorial in nature. It promotes maximum community self-reliance and participation, be sustainable and integrated with the referral system, and it relies on all cadres of health workers. Know the secondary healthcare. It is more complex problems are dealt here. For example, in mother and child health care, the services that cannot be provided in basic health units and RSs, they should be dealt in secondary healthcare like THQs, like cesarean section are carried out in secondary healthcare hospitals. It comprises curative services and it is provided by the THQs and DHQs. Now the tertiary healthcare services. It offers super specialty care. Uh, those cases that cannot be managed at primary and secondary healthcare level are managed at the tertiary healthcare level, and it is provided by the regional central level institutions, and it also provides the training programs. Now the primary healthcare in Pakistan. Pakistan embarked on primary healthcare services provision for the poor prior to the 1978 Alma-Ata Declaration of Health for All by the year 2000, and during the 5th and 6th year plan during the 1978 to 1983, 492 RSCs are built and 3496 BHUs are built. Primary healthcare provides a link between villages, marginalized population, and the whole health system. Now, the basic health unit. It serves a population of about 5,000 to 10,000 people, and the services provided in BHUs are mother and child health care services, child health care, immunization, diarrheal disease control, malaria control, child spacing, mental health, social health services. Outreach services will be provided primarily for mother and child health through training of birth attendants. 5 to 10 BHUs will be linked to a single RSE. Now the structure of a BHU. This is an organogram taken from one of the BHUs in the Punjab. In BHU, the topmost seat is of the medical officer, and there are facility services and outreach services. In facility services, there is a dispenser whose job is to for dispensing the medicines, giving injections, dressings, stitching, and assisting the medical officer. And the second is the LHV, whose job is to for giving the mother and child healthcare services, conduct deliveries, outdoor therapeutic procedures, immunization, and other activities. And the other is midwife, which assists the LHV in carrying out the activities. And other are the chokidar and aya, that are the class 4 workers. And the other are the outreach services, that are the school school health and nutrition supervisor, whose job is to uh, uh, provision of school health services to the children in the schools. He take good care of their personal hygiene, and if someone has having a medical issue, he refers them to the BHU. Next is the CDC supervisor, whose job is to for the control of the infectious diseases, like in dengue and malaria control program. He takes blood samples of the people in the community and send them to the laboratory. Third one is the sanitary inspector, whose job is to maintain the sanitary conditions in the community. For example, he give education to the people in the community about the removal of the heaps of garbage, and removal of any stagnant water in the community. Fourth one is the vaccinator, whose job is to vaccination of the children according to the EPI, and also the vaccination of the women of the reproductive age. And the last one is the lady health supervisor, whose job is to supervise the lady health workers. Now the rural health center. Rural health center contains about 25 patient beds. There is a laboratory in it. There is the facility for X-ray there, and it provides facilities of minor surgeries, and the dentist facilities are also available there. RSC is linked to THQ when V10 is linked to DHQ. The whole system BHUs, RSC, THQs, and finally DHQs is designated as integrated rural health complex. Now the structure of RSC. This is the organogram of one of the RSCs in Punjab. In RSCs, there is one post of additional principal medical officer of grade 19. There is one post of senior medical officer of grade 18, and there are 3 to 4 medical officers, one WMO, and one dental surgeon. And there are also charge nurses there, and there are also homeo doctors and computer operators there. There is a technical technician, LHV, and laboratory technician there. There is also a clerk there, and there are also the persons technicians, that are the radiographer or operation theater attendants, dispenser, vaccinator, and rural dispensary, and rural and health dispenser, and other class 4 workers such as PNs, sanitary worker, security guards, etc. Now the primary healthcare planning. In RSCs, there is also the facility of specialists there, like the gynecologists, general surgeons, medical specialists, and the anesthetists. Now the key concepts in primary healthcare planning. Number first is equity. Everyone should be entitled for healthcare. His needs should be taken into consideration. Together, both the statement means that everyone should be provided care as per their needs, as everyone's needs are not equal. Providing services to people according to their needs is important. However, without efficiency and effectiveness, they fail to have an impact. Equity differs from equality. Equality means that the provision of services or facilities to all the people in the community, irrespective of their needs. Know the effectiveness. Each primary health program activity such as EPI should have its impact measured through various indicators. Effectiveness lacking in equity and efficiency would mean loss of desired force of effectiveness. Efficiency. Where the primary healthcare programs are undertaken, they should be low cost and consistent with favorable effect. To have efficiency without equity and effectiveness means inaccessibility to large section of population to obtain desired results. Now, the second part of the presentation is referral systems. Introduction. It is a process in which a health worker at one level of health system having insufficient resources like drugs, equipments, or skills to manage a clinical condition seeks the assistance of a better or differently resourced facility at home or high level to assist in or take over the management of the client's case. Now, the reasons for referring. The patient may be referred to seek the additional or different services for the client, to seek the expert opinion regarding the client, to seek use of diagnostic and therapeutic tools, or to seek the admission and management of the client. This is a flowchart diagram of the referral system. If a patient has a problem, he will visit the general physician. If the general physician can solve the problem, the patient will be sent to home and he will get, if he gets healthy. If the general physician cannot solve the problem, he will refer the patient to some other facility that uh, has that specialty. Now the referral process. Referral process starts with primary care physician orders a referral, and then primary care physician communicates referral to the specialist, and then referral reviewed and authorized, and appointment scheduled. Consultation occurs. Specialist communicates plan to the patient and to the primary care physician. Primary care physician acknowledges receipt of plan. Primary care, and at the last, primary care physician communicates plan to the patient or his family. Now the benefits of referral system. It is an effective referral. If an effective referral system ensures a close relationship between all levels of the health system and helps to ensure people receive the best possible care closest to home, and it also assists in making cost-effective use of hospitals and primary healthcare services. It's supposed to health centers and outreach services by experienced staff from the hospital or district health office helps build capacity and enhance access to better quality care. In many developing countries, a high proportion of clients seen at the outpatient clinics as secondary facilities should be appropriately looked after at primary healthcare centers at lower overall cost to the client and the health system. The benefits for the patient are it promotes diagnosis and management, it saves the time, money, and effort of the patients, and it has better outcomes. The benefits to the family physician is that it helps in learning and training of the general physician, and it helps them to gain self-confidence, and it improves the communication between the healthcare staff. And for the consultant, benefits of primary healthcare is to improve the quality of the patient management, increase the communication between the healthcare staff. Now the disadvantages of self-referral and direct access to the hospital. If the patient has self-referral and directly access the secondary or tertiary healthcare hospital, there will be the insufficient care to the people of the community. The patient has to wait longer, and the lack of continuity and follow-up, losing way between hospital and different sectors, and wastage of resources at all the levels. On the self-referral, clients bypassing lower level services is a common problem which leads to overcrowding of higher level facilities. It is essential to strengthen primary healthcare services to make them effective and credible in the eyes of the clients. In overcrowded hospitals, explain those who bypass their primary health services why they have to wait longer. In addition, penalty fees charged to those who arrive at higher level facilities without a referral letter or other clear indication of necessity may also have to avoid unnecessary use of these expensive facilities. But emergencies and very serious cases should always be seen promptly. Intensive public communication and education is essential to inform the public who, where, and when they should seek health care at different levels, and to build their confidence that lower level facilities really can offer acceptable quality care when they need it. A good referral system can help to ensure client can receive optimal care at the appropriate level and not unnecessarily costly. Hospital facilities are used optimally and cost effectively. Clients who most need specialist services can accessing them in a timely way. Primary healthcare services are well utilized and their reputation is enhanced. Now the referral system model. A patient is referred to the community health worker by his family or the community or the individual himself, and if they are not managed at the community health center, then they are referred to the district health centers, and if they are not managed there, then they are referred to the provincial hospital and centers, and if they can when they can if they are not managed in provincial hospitals, then they are referred to the national hospitals. Now the components of our referral system. There are 5 components. The health system issues initiating facility, referral particularities, receiving facility, and the last one is supervision and capacity building that are discussed in detail here. Number 1 is health issues. In this, the A part is service providers and quality of care. For a referral system to work at its best, relations between service providers are formalized and referral procedures agreed. All levels of health system, including primary healthcare services, need to be functioning appropriately. This includes each facility has the available protocols of care for that level of service, having suitable means of communication and transport, being clear about their role, responsibilities, and limitations. Now, the initiating facility. The facility that starts the referral process is called the initiating facility, and they prepare an outward referral to communicate the client condition and status. When a client visits the health center, it is important that the health worker attends to them promptly, treats them with respect, privacy, and confidentiality, acknowledging their culture, beliefs, and identify their needs. The health workers assess the client, gather relevant information, and provide any necessary care possible at that facility. In an emergency situation, the health worker must maintain all vital functions and minimize any further damage. Making the decision to refer the client comes after the health workers has gathered and analyzed the relevant information using the protocol of care as a guide. Deciding to refer does not mean that the health care worker is inadequate or bad. On the referral party qualities, a referral form that is standardized throughout the network of service providers ensures that the same essential information is provided whenever referral is initiated. The referral form is designed to facilitate communication in both directions. The initiating facility completes the top part of the top part or the outward referral. Every patient referred out should be accompanied by a written record of the clinical findings, any treatment given before referral, and specific reason for making the referral. The referral form should accompany the client, often carried by them, and give a clear designation of to which facility the patient is being sent. A carefully filled referral card can help the client get timely attention at the receiving facility. This is the referral form in which there is the data of the patient uh, and the initiating facility that refers the patient is also mentioned here, and according to medical history findings, treatment given at that facility, and the reason why they are referring the patient to other facility are also mentioned in the referral form. This is the referral form when the receiving facility sends back to the patient. In this, it is mentioned that the whether investigation, treatment, or medication they have given. Now, if the client is very ill, it might be necessary for a health worker to accompany them to the receiving facility. In some situations, it will be possible and necessary to communicate with the receiving facility to make an appointment or other arrangement for the referral, or to let them know for the pending arrival of an emergency case. The decision to refer might be frightening or distressing for the client and their family, so it is important that the health workers have empathy and give the client relevant information such as reasons and importance of the referral, risk associated with not going, the process of follow-up on their return, who to see and what is likely to happen, how to get to the receiving facility, and the location and transport. Health workers can show empathy in understanding the implications of referral for the client and their family or support network. The client may be frightened of the unknown, frightened of becoming more ill or even dying, and he may be concerned about meeting the cost of the transport, treatment, and family accommodation. He may be concerned about leaving work that needs to be done. Know the referral record. Each facility in the network should have a referral register to keep the track of all efforts made and received. Information from the register is used to monitor referral patterns and trends. And these are the referral registers for outgoing patients and for the patients who are referring in the facility. On the receiving facility, the facility that accepts the referred case is called the receiving facility, and at the end of their involvement, they prepare a back referral on the lower part of the forms to let the initiating facility know what has been done. If for one, the receiving facility can anticipate the arrival and receive the client with their referral form, they will use the information sent on the referral form to begin a thorough assessment of the client and begin management of the case. The receiving facility will use its particular resources to provide the client high quality care and maintain documentation according to the agreed standards. As the client progresses, the receiving facility will plan the rehabilitation or follow-up program with client and their family or the support network. When the client care have finished at the higher level facility, back referral to the original facility is important. The receiving facility completes the lower part of the referral form. This communication contains the information of special investigation, findings, diagnosis, treatment given by the higher level facility as well as follow-up as expected from the lower level facility. The back referral form can be delivered by the client to the initiating facility, but may also be sent by fax or by the means of post. This communication not only assures proper patient care and follow-up, but also provides continuing education to the initiating facility and their staff